And welcoming everybody, encouraging engagement. You know, this is an interactive session. We'll have a Q. Before we get started with that, I do want to share a quick program, just some information that we're working out of the Center for Rural Health. And it is called the RAD-IT program, Responding to Adolescent Depression through Integration and Telemedicine. This is a program and a grant project that we're working out of in coordination with Alterum Group. And its goals are to integrate the behavioral health access into primary care setting, also to help clinicians utilize telemedicine to increase behavioral health care access, and to improve the outcomes for rural Michigan adolescents. Again, this is just a program that we're working on out of the center to be able to assist our RHCs with some additional services. Additionally, as I said, Alterum, along with us and Upper Midwest Telehealth Resources and Cisco, our goal will be to train 45 primary care clinicians to provide universal screening for depression among adolescents, enact appropriate follow-up protocols and monitoring, and establish telehealth services linking vulnerable youth to the providers who specialize in adolescent mental health. We know mental health is very lacking in a number of our rural communities, and we're hoping this program will assist some of those rural communities to fill that gap. So why participate? We will be providing telehealth equipment and a 3-year subscription to Cisco. That's valued at about $5,000. Practices can use the equipment for all of their patients, regardless if they're an adolescent or an adult. And upon completion of the program, it'll be theirs to keep. We will offer free continuing medical education and maintenance of certificate credits for those providers who participate. Additionally, the program's going to offer a dedicated practice coach to be able to help you integrate the depression screening, treatment, telehealth services into the practice, and also regular performance data around screening, identification, treatment, and follow-up of adolescent depression. In order to participate, you do have to be located in one of the following counties: Allegan, Mason, Oceana, Hillsdale, Grand Traverse, Benzie, Manistee, Macomb, Clare, or Gladwin counties. We know that is limited, but this is what the program helped dictate as some of the highest needs for adolescent screening and for depression. You have to also not be yet conducting that universal depression screening with their pediatric patients. For the practice itself, you need reliable internet connection, and then also have and be actively using your EHR to maintain patient records. So just a kind of a brief overview, you would receive technical assistance and practice coaching. One of the additional things that I'm really excited about for our practices as you go through the rest of the webinar today is that dedicated practice coach to work through some of those workflow and billing issues. We know telehealth is new, not so new, but newly available. Also to work through that data collection and evaluation. Again, receive that telehealth equipment. You would be part of that telehealth network, and then we would also provide you capabilities that were in your direct area, and then have training curriculum and resources. So again, this is a really brief overview of the project. We wanted to be able to provide you that information. The next steps would be, we are starting that recruitment process now, a June or July kickoff. The program is just over a year long. So if that's something that you're interested, we're gonna put up a quick poll. Danielle, if you can launch that poll and has a couple quick questions, then we'll launch into the webinar on telehealth and financial sustainability. So while that poll is out, Danielle, can you tell me if the poll is launched? I can't see it on my screen.
Yep, our viewers should be able to see it and respond to it. We've got a couple coming in so far.
Perfect. So really the poll is to help us gather that information to make sure that this is a valuable program, also to gain interest, and we'll be contacting those clinics who are interested. And if you know of anyone who might be interested in one of those counties, feel free to share this information. We'll be sending out the slide deck post the webinar. But first and foremost, we are here to talk about telehealth and that financial sustainability. I want to welcome the Rybar group. They're such a strong partner for us, and we really appreciate them. This is something that they were interested in from the get-go when I reached out to them. First and foremost, we have Julie Hardy. Julie graduated from Ferris State University with a bachelor's degree in healthcare management and earned a master's degree from Central Michigan University in healthcare administration. She maintains multiple credentials from the American Health Information and Management Association. Julie has spent her career focused on helping providers to increase revenue in a compliant way through her experience in coding, billing, and compliance for a variety of provider types. Julie is able to assist practices with operational improvements in an efficient manner. She's been, again, a great resource at many of our network meetings. Additionally, Karen Polwolowski, hopefully I said that right, Karen, or at least close. Karen graduated from Saginaw Valley State University, earning a bachelor's of business administration degree. She is a Healthcare Financial Management Association member, achieving certified healthcare financial professional status. Karen has over 25 years of a financial experience in rural healthcare, with the majority working for providers. As rural healthcare reimbursement consultant, her passion is ensuring that providers receive the appropriate designation and then utilize the enhanced reimbursement opportunities to their full potential. They're a wealth of knowledge, and I do want to welcome them. I'm going to go ahead and stop my share and then allow them to kick off their presentation.
Thank you, Jill. Just give me one moment while I share my screen. All right, so let me get into presenter mode. And click share twice. All right, can everyone see the slides on my screen? Well, the slide, there's one slide.
Yes, we can, Julie. Thank you.
All right, thank you. All right, Jill, thank you so much for the introduction and inviting us to be here this morning. We're really excited to be here to talk to you. Of course, we want to make sure that everyone knows that new laws, new guidance, new regulations are literally being written as we speak this morning. We're going to do our best to answer all of the questions you have this morning, but just know if we don't know the answer or if there's not yet an answer published, we will definitely be sure to get back to Jill and the team with the Michigan Center for Rural Health so we can get you all of the information that you need. So just know our slides are updated as current as we could get them. So bear with us if anything that is on our slides has changed in the last 24, 48 hours. It may not have made it onto the slides, but we'll make sure to get all of the information we can to you. So our objectives for this morning, I'm going to talk to you a bit about telehealth, talking about the current state of it, documentation, coding, billing, and reimbursement, both for Medicare, Medicaid, and for commercial payers. And then Karen's going to jump into some of the more financial information related to cost reports and additional funding opportunities and things of that sort. And I do believe that Danielle will be compiling the Q&A as we go, so we'll make sure that we can answer questions at the end. And we'll go ahead and get started. So like Jill said, telehealth is not necessarily a new concept, but the waivers that have come out over the last 2 months are the new concept. So it used to be fairly limited in terms of where telehealth services could be provided and to whom they may be provided. So they offered a wealth of waivers, and they continue to publish interim final rules, waivers, new guidance, new Q&As. Like I said, basically every day. I'm sure they're writing some as we speak this morning. But some of the big ones that came out that affect rural health clinics are that effective March 6th, rural health clinics may furnish, telehealth services as the distant site provider during the public health emergency, and services may be furnished from any location to a patient in any location. So this is where everything came to be. The patient could be at home, the provider could be at home, and basically HIPAA rules are kind of set aside so that these services may be provided in a safe and efficient manner throughout the public health emergency. And of course, kind of the elephant in the room that Jill and I had a conversation about earlier this week is, well, what's going to happen when the public health emergency ends? And, you know, I wish I had a crystal ball, but I don't. There is definitely some information coming out from CMS that they feel that these changes that they've made to telehealth are good and they should be permanent. However, there's a lot of work behind it in terms of updating all of the laws, all of the regulations. So it's hard to say what it's going to look like when they say, I believe the exact quote was, the genie's out of the bottle and we can't go back now. It's hard to say what that's exactly going to look like. And also, we don't necessarily know when the public health emergency is going to end at this point. So we're going to plan as if telehealth may go away, while hoping that it won't, and that there can be some successful advocacy for fine-tuning some of the reimbursement and requirements around it. I'm kind of getting ahead of myself a little bit. So telehealth services may be provided and billed to new and established patients. That's also a waiver that came out and pretty key for those of you who see a wide variety of patients in your clinic. So the first code that I'm going to talk about is G2025. So I'll also be covering G0071 for the virtual services, but G2025 generally covers all of the telehealth services that you're going to be providing. Any telehealth service that is on the CMS list of approved telehealth services, whether it's for the PHE or permanently, are going to be billed under this code with the exception of the virtual communication services that I will talk about next. So for G2025, looking specifically at what needs to be documented at the time of the encounter, patient consent, and that may be done at the time of the encounter, and it may be done verbally, and it may be done by ancillary staff. Also, it's recommended that you obtain verbal consent if you're not using a HIPAA compliant platform. From there, aside from your typical documentation, you're always going to document the reason for the visit, your history, exam, medical decision making, what was discussed, what your plan of care is. You're going to document the modality of the visit. So whether it was FaceTime, Mend, or Zoom, you do not need to keep a recording of the visit in your medical record or elsewhere. Again, it's like as if the patient were there in person. And your medical record documentation is the summary of what happened while the patient was there. You don't record them while they're in the office, so you don't need to keep a recording for telehealth services. A lot of the services that you're providing that fall under G2025 are also going to be time-based services. So when that's the case, such as phone calls, things of that sort, make sure that you're documenting the time of the visit, the length of the visit, and generally start and stop times as well. I do get into that a little bit later. So before we move on, I want to talk a little bit about the examination, because I get a lot of questions about what it looks like for a provider to do a physical examination remotely. And this has always been an underlying question because Medicare has allowed annual well visits to be billed via telehealth for a couple of years now. And everyone gets hung up on the examination portion. So if it's a problem visit, it's a little bit easier because if you're doing a video or if you're doing a phone call and the patient sends a picture after, it's fairly straightforward because they might be sending you a picture of a cut or a rash, or if their knee hurts, they'll send you a picture of their knee. So that's pretty easy. And if you're FaceTiming or doing Zoom, you can cover certain things. So the provider can document what they notice in terms of their head, face, and neck. How does that appear to them? They can ask the patient to move their phone or computer so they can see a swollen joint, things of that sort. And what's key is to make sure that the provider documents exactly what they see. They're still going to be able to cover a lot of that general information, like the patient's mental status, things of that sort. So don't get held up on a physical examination as part of a visit. Now, for those services that require vital signs, Medicare has not provided official guidance, but they've verbally said that you can use the most recent visit. and just document whether or not you anticipate their current treatment plan having changed that. So for example, say one of your patients is having a telehealth visit via real-time audio and video communication, and it's because they have high blood pressure. So you're not going to be able to take their blood pressure with your own equipment. But if the patient has a blood pressure cuff at home, have them take their own blood pressure and show it to the provider while they're on the call. If they don't have their own blood pressure cuff, then they should document the blood pressure from the last visit, and then any interventions the patient has taken in the meantime and how they're currently feeling. So say the patient has hypertension and they now have headaches. That's going to be key for the provider to document, and with that, they may change the plan of care. So anything that they can do that's pertinent to the visit is what they should be documenting. And we also understand that they can't move mountains and they're just doing the best they can. So I can't stress enough that we always say if it wasn't documented, it wasn't done. If you think it, put it on paper. That's how we train our providers. But make sure that they really understand that when they're changing a plan of care for something they can't physically touch.
Miss Julie, I want to add that if individuals do have questions, there is a question box at the bottom of your screen, and we'd be happy to answer questions as we move through the webinar today.
Yes.
Thank you. And it looks like we do have.
Oh, Jill, you muted yourself.
Oops.
Okay.
I have a question. I'm not sure if you can see that.
I can. A frequency limitation for billing G2025. No, there's generally not, because the services that you're providing don't have the frequency limitation. So we are going to talk about it related to G0071, which you call out in your question. But for G2025, there's not, because this could be a patient who comes into the office twice in 1 week. Maybe they come in for chronic conditions and then a problem visit. Those are the types of services that fall under this code. So there's not going to be a visit limitation for these. And I will keep the Q&A box open over here, so I will try to keep an eye on them, but definitely if I miss one, someone just shout out to me.
We do have a couple more, and this is actually the Zoom webinar chat.
Okay.
From Linda Mueller, do you know of a resource where patients can get free or low-cost blood pressure cuffs?
I do not know of a resource. However, I will talk about this in a later slide as part of Karen's portion of the presentation with the FCC TeleHealth grant. An option is for you to purchase the equipment for the patient. And if you're monitoring the patient remotely, like having them send you blood pressure logs, you can get that service reimbursed by the FCC. So I will talk about that a little bit more in depth later, but in terms of somewhere where your patients can go to get a reduced cost blood pressure cuff, I'm not aware of that resource right now.
And we certainly can try to find some of that information as well. And one more, can you do, and you may be discussing this later, but can you discuss documentation service requirements for delivering annual wellness visits via telehealth?
Yep. So I did talk a little bit about the physical exam, and the annual well visit requires vital signs, height, and weight. Those may be provided by the patient, or like I said, you can pull it from their most recent visit and just talk about anything that may have changed based on your conversation with the patient. Aside from that, HRAs and things of that sort can be provided remotely, and you can have the patients review them and sign them remotely. All of the 11 elements of an annual well visit are not coming to me in this moment. But if you do have any more questions, more specific questions, please put them down and I'll make sure I follow up on them. So in terms of billing G2025, don't memorize this because it's probably going to change again, because we were initially told to bill it with a level for your E&M or whatever service you provided with modifier 95 until July 1st. But as you probably know, last week they changed that and instead bill G2025 with a CG going retroactively back to January 27th through June 30th. So Medicare is saying they're going to reprocess those claims, but definitely make sure that you're tracking those so you can make sure that everything is reprocessed as it should be. They're also saying modifier 95 is optional. My personal opinion of this is don't put more information than you need. So I am not recommending anyone add modifier 95, though I am hearing that there are certain MACs, not necessarily WPS, but some are being more strict about it and they want modifier 25 or modifier 95. If anyone's heard anything different or if you've received any denials from WPS, definitely let us know in the chat. So starting July 1st, you're still going to build a G2025, but you don't need the modifier. Now, one thing to keep in mind is that if the visit leads to an order for a COVID test, then you're also going to apply modifier CS. So it'll be CG, then CS. The payment's going to be $92.03, and this also is going to include audio-only visits. So it's going to include telephone encounters, and these services must last at least 5 minutes, and they cannot be billed if they're originating from a related E&M service within the previous 7 days or lead to an E&M service or procedure within the next 24 hours or soonest appointment. So the key there is related services. If it's different than a recent E&M visit, then it's okay to bill it. And I do see there's another question. Okay, so someone said that the July 1st date and reprocess has changed. I have not seen that, but I can definitely follow up and I'll let you know if I find new information. How often can 99491-3 be billed? So I don't have as many codes memorized as you may think. If those are telephone visits, there's not a limitation on that. I'm sorry, just let me contemplate this. Well, I am actually going to have to follow up on this because I'm not exactly sure what codes those are. So let me just follow up on that after the webinar. And then there's another question, what does a related E&M service provided within 7 days mean? So again, related to that condition, it has to be the same reason that they were already there. Okay, thank you. So telephone only codes. There's not a limitation as to how frequently those can be billed. I wouldn't bill it more than once in a day, but you can bill them multiple days in a row. And yes, D2025 includes telephone visits only. That was part of the changes last week. All right, so I am going to move on to G0071. So these are those virtual communication services, and they're not face-to-face, they're patient-initiated, and it's digital communication via a secure portal, which means that the patient has their own login and password, and they have access to a provider 24/7. And it also requires clinical decision that otherwise typically would have been provided in the office. So the RHC practitioner can respond from any location during a time that they're scheduled to work in the RHC. So what you're going to want to document for this is the date of the patient contact, date of the provider response, total time spent each day, because this is 7 days cumulative, and I'm going to talk about that a little bit more in the next slide, and then a brief description of the activities and care provided, and whether or not it's a new or established patient. I'm going to take a quick look at the questions. Okay, thank you. That makes more sense to me than 99441-443. Okay, yeah, so still my answer holds for the telephone codes. So here, always keep in mind, in the coding and billing world, there's no limitation as to how often these can be billed, the telephone visits. Payers may have entirely different interpretations that they haven't even thought of yet, because if they feel as though they're being billed too frequently, they're going to put a frequency limitation on it at some point. But as of right now, there's not one. So let's move on to billing the G0071. So this used to have a reimbursement of $13 and something, $13 and change. So after March 1st, 2020, and try to keep up, some things are the 1st, some things are the 6th, some things are the 16th, no standardization, but $24.76 for the duration of the public health emergency. All right, so the MACs are saying they're going to automatically reprocess any claims with G0071 furnished on or after March 1st that were paid at the $13 rate. Again, check all of these to make sure that they actually reprocess all of them. And this is the one that cannot be billed more than once every 7 days, because you're going to bill it once a week, essentially, for all the time you spent over that week. So you're not billing it on a daily basis. So say you respond, your provider responds in a portal and they say, so the patient says, I have a rash. That's not a good example. Let's continue with chronic conditions. So let's say that they're monitoring their glucose at home, they're diabetic, and say their fasting glucose is up a little bit. So they respond in the portal, and your provider goes back, answers their question. The next day they go back, ask another question. The next day they say, okay, this is how we're going to change your medication. All of that time for those 3 days should be added up and billed once. All right, I do not see any new questions yet, so I will keep going. And also keep in mind, when you're billing to your commercial payers or any of your payers who don't reimburse based on an all-inclusive rate, documentation of time and acuity is going to be key, because there's different levels of these codes, so you're going to get reimbursed more for the higher levels. I did want to make sure I touched a little bit on Blue Cross Blue Shield, because they're a significant payer here in Michigan. So if you look at that second box, for the most part, they're following what Medicare is doing. They do have a different start date, which is March 16th, and they do, at least as of right now, have an end date of June 30th for their telehealth coverage. But there is a link to the telehealth procedure codes, and it mimics CMS's list.
Julie, I'm gonna back up for just a second. We do have another participant on the line, and it is indicating these are now all billed with the G2025 and paid 9303. If you look,
I see that now. If that's referring to G0071, at least as of the last communication that came out from Medicare, it's still at $24. The last communication I have, I believe, was
I know some more came out the end of last week.
Right, yep, that's what, and as of last week, they were still saying G0071 is the virtual communication that doesn't require the real-time communication is still going to be billed under G0071 it's a higher reimbursement than it was. But telehealth does not yet include asynchronous communication, even in a non-rural health world, with if you're billing other codes, not the G codes. So that's, at least I've not seen anything change on that, but I am more than happy to follow up if something did. But again, it's only talking about the asynchronous communication, which Medicare does not consider telehealth, which is why it has the lower reimbursement. Although, Jay Quinn, if I am misunderstanding, definitely let us know and I can talk more about it. All right, so I am going to take a break and turn it over to Karen to talk about some relief funds.
Thanks, Julie. Just keeping in mind, this is like a quick summary of all the different relief packages and funds out there. Many of them are available. We're going to briefly touch on them. Hopefully the majority of the participants online are already aware of all of them. They're using them as an opportunity to strengthen your cash flow, your cash position. Keep in mind, with a lot of these programs, the funds have been distributed very fast, with the guidance coming in a lot slower. And with some of these funds, the guidance still hasn't even been produced yet or published. The CARES Act was actually signed on March 27th for $100 billion. The Advanced and Accelerated Payment Program came out within a week. The HHS First General Distribution came out 2 weeks later. And again, these sources of funds have been coming out extremely fast. There's various sources of funds, both some that have already occurred in the past that are done, or at least have stopped at this point in time. They're not accepting new applications. There's some that are currently available, and then there's also some future funds that'll be available as well. Keep in mind that all rural health clinics are not eligible for all these sources of funds, and there is sometimes a difference between the provider-based and the freestanding rural health clinics. With the provider-based participants on the phone, I realize a lot of your funding opportunities, elections, and attestations is probably coming more through the hospital, because that is where your tax ID number is assigned to. So generally speaking, the finance department at the hospital is the one taking care of these. But it's still important for you on the rural health clinic side to still be aware of the opportunities and the requirements, more importantly, that exist to receive some of those funds. With the freestanding rural health clinics, again, they're more directly involved with the cash and the finances, and I'm sure they have read everything that I have and have seen all the different publications as well to keep up on that. So first, we're going to talk about the Medicare Advance Payment Program. Can you move the slide, Julie? Sorry.
Yes, sorry, I'm on it.
Thank you. With the Medicare Advance Payment Program, so this is kind of considered a short-term interest-free loan to a certain extent. It's not a grant. You have to pay it back. You can, at the point in time when it's time to pay it back, again, hopefully the majority of you have already received those. If you haven't received it yet, the application has stopped. But if you have received them, they will have to be paid back. If at that point in time that you need to repay it back, or even now, if you think it's going to be a financial hardship, reach out to your MAC, WPS, and renegotiate a payment plan. And more importantly, develop a plan right now for how you're going to pay that loan back. Again, when the funds were distributed, they were distributed fast. They wanted to make sure everybody still received them as soon as possible to get those funds flowing. They will begin 100% automatically withhold on day 121 with the Medicare claims offset. So just keep that in mind. On day 121, after you received your funds, they're going to automatically start withholding 100% of it unless you've renegotiated that payment plan with WPS. They will then continue to withhold for 210 days. They will then send you a 30-day notice if it's not paid in full. That is your time to pay it back. There's nothing saying you can't pay it back before that. Personally, I would strongly discourage it because if you send a check back to the MAC right now for them to try to apply it to the right loan to make sure it's approved or closed properly, I would get that 30-day notice. If you haven't paid it back before then, send it back in at that time. The interest rate it actually dropped, believe it or not. 9.625 is actually lower than it was. It was over 10%. They just dropped it yesterday. But keep in mind that interest that you would have to pay after that 8 months is not allowable on your cost report. You'll have to offset that. So this would be one of those examples that it was nice to get the cash up front, but it would probably be better to pay it off before that 8-month time expires. There are no new applications being accepted as of right now, but there are a lot of other non-loan opportunities that you will not have to pay back that are available to you. So next we'll get into the paycheck protection loans. Again, I'm hoping that the majority of rural health clinics on the line have been able to receive these funds. The first round was started again within a few days after President Trump signed the CARES Act. It is, again, fully funded by the SBA or secured by the SBA. The first fund went through, the cash went through extremely fast. These, again, are designated as a direct incentive so that your businesses can keep workers on their payroll. So it's to try to keep people off unemployment and keep them employed. The first round went through really fast, ran out of funds. The second round started last week. There are still funds available. So if you have not secured funds through this, and if you are independent especially, jump on and get those funds coming through your local bank. If you're part of a system or a hospital that has more than 500 employees, there's a chance you're not eligible. And they did release additional guidance last week that you can actually be government owned and you are still eligible as long as less than 50% of your funding is not from your state and local sources, including Medicaid. And then we've included in here frequently asked question link. It's really important to look at that often. They are changing that constantly. And the other thing that they recently also came out, and I don't think any independent rural health clinics would be under this scenario, but there could be some provider-based clinics under this scenario, that if you have any loans in excess of $2 million, they are going to start auditing them. Every single loan in excess of $2 million will be audited. So moving on then, looking at the forgiveness piece of it, this is one of those, hopefully everybody's looking at as free money. So yes, it's a loan, it's considered a debt, but there's ways to get it 100% offset. So keep in mind that if you received a loan within the first part of April, you are already halfway through your 8-week session, if not longer. So 8 weeks starts when you receive their funds. And it's really important to make sure that you have everything set up, that you have your expenditures in line, you have your documentation in line to ensure that you are able to get 100% of that loan forgiven. So payroll has, for the forgiveness piece of it, payroll has to be 75% of it, including the health insurance. So depending on how you apply for that loan and the time frame you used and the expenses that you had, it's really important to keep that payroll at least 75% of the loan forgiveness, because then you can get the full 25% maximum forgiveness for your other costs, such as mortgage interest, leasing, utilities. And there's a couple of different ways that can't happen. One, if your total costs aren't there, and then also through your statutory reduction. So if you decrease your number of FTEs, and I put on the slide a few different examples of different denominator timeframes, or if you had pay cuts for employees making less than 100,000 for more than 25%. And they are looking there at a very specific employee by employee comparison by pay period. So keep your documentation in line so that you have an Excel built for every employee, how much they were paid before for your base period, and then getting into how much they are getting paid by period for those 8 weeks. Jumping on to the next slide. If your loan is not 100% forgiven.
Sorry, I'm there now.
If your loan's not 100% forgiven, keep in mind that if there's some piece of that you're not able to support, either you have less than 75% for payroll, so then you can't get the full 25% for your other, or if for some reason you can't, hopefully everyone can fully get the 100% forgiven. It's kind of free money. Take advantage of it when you can. If you can't get it forgiven, it basically turns into a 2-year note at 100%, or at 1% interest, which is extremely low interest rate. It can go on the cost report. This loan balance can, because it's not being paid directly to Medicare, and you can always pay it off early too. So again, there's other sources of funds that are available. If you're able to obtain those, this is another example of a short-term use, but if you can get 100% forgiven, work through that. There's still, again, another example of a lot of funds are available, but there's still a lot of guidance that's still needed. They have talked about the cash versus the accrual. Is it looking at the 8 weeks from who's paid in those 8 weeks? Is it looking at the accrual side? If you're including rent you are paying, is it looking at when you pay the rent and happening within those 8 weeks? So can you prepay a month, or is it only for the month that you normally be paying for? They haven't fully disclosed what health insurance includes. Doesn't include dental, vision, and other sources of insurance that the employer is paying for. With the retirement side, some organizations have retirement plans that even though they're incurring them throughout the year, they only pay it once a year. Again, it goes back to the cash versus the accrual basis. Again, those frequently asked questions are updated constantly. They're continuing to come out with more and more guidance. There's still funds available, so if you haven't gotten them, please apply for them through your local bank. What we're recommending to the client is record those funds as debt. Technically, the day you receive those funds, it is a debt that you will have to repay back unless it's forgiven. Once it's forgiven, there's not guidance out there yet if it's going to be considered a grant or if it's going to be forgiveness. And depending on how they forgive that will depend on how it will be treated on your cost report, which we'll talk about in a few minutes. And there are some examples of companies, I think there's very few that would be on this call for small rural hospitals or rural health clinics, where there are some companies that have secured the funds or received funds that technically didn't meet the criteria. You had to be able to show that you needed the funds, and I don't know of any healthcare organization right now that doesn't need funds to cover their payroll. But for some of the other industries, if they received the funds, they can return them under a safe harbor by May 14th and have no federal penalties or concerns. I'm hoping this will help open up more funds even that are available for additional providers as well, which is going to be essential in the future. Over to you, Julie.
Thank you. So before I talk about the FCC telehealth program, I do see Jay Quinn. I apologize, I don't know your name, though I would probably know your face if I saw it. But I do see what you sent in the chat. So what is in there is the telephone codes, right? So that's what I talked about, that the audio only goes under G2025. So yes, telephone codes, G2025, the $93 reimbursement, definitely. It's those virtual communication services that are not real time that goes under G0071. And it's mostly limited to the patient portal. So that's the difference. So the telephone codes, yes, G2025, not real time via portal, G0071. So if I'm still missing something, please let me know.
Julie, this is Jill again. Julie Quinn is from Health Services Associates. Hopefully I'm remembering correctly. And she also definitely works within this scope in terms from Health Service Associates. Julie, I know you're unmuted, and if you have anything to add, feel free.
I really don't, and I just was chiming in here because I knew, man, this stuff's changing so fast. My goodness, I mean, you can wake up in the morning and everything that you knew yesterday
is wrong.
Completely turned upside down. And as you said at the beginning, they're probably changing rules right now and going to turn it all upside down again. I just really got on here because we do cost reports, and I wanted to see, what other people's perspectives were. Karen, what you were saying about what I'm really looking forward to your next few slides on what, forgiven and non-forgiven and what we're going to have to offset and that kind of thing. But I know this came out from NARHC. I let people that are way smarter in billing than me figure this stuff out, like you, Julie Hardy, in telling them, and I'll just let you guys finish up on what is a GO 071. I just know they did add audio only.
Yes,
And
you are 100% correct.
And I think I was a bit confused as those slides were going because it sounded like audio only didn't count, but you're saying it does.
That's correct. Audio only. It's the asynchronous that does not.
Yeah, yep. And then I know that the billing changed where you don't have to wait till July 1st to do this code.
Right.
And the CG modifier 95 is optional now. Does that make sense?
Yes, and CG is not optional. 95.
I'm not sorry. 95. Sorry.
Yep,
95.
exactly. Yep.
See,
Yeah.
you guys are way more in the know than I am. I'm just kind of had knew that again, you can wake up tomorrow morning and they're going to change all this again. Thank you, ladies, for helping and navigating us all through this. I'm going to go back on mute.
Absolutely. Thank you for your questions. I do appreciate it. And of course, love that your name is Julie, and I will never forget that. So I will talk real quickly about the FCC telehealth program. So you guys may be aware of this because the FCC has provided telehealth funds for rural providers for many years now, but they've expanded it for the COVID crisis to help provide and allow for more services and more telehealth services across the country. So if you're not aware of this, for the most part, I think most people on this call are going to qualify either as an independent rural health clinic or as part of a not-for-profit or nonprofit hospital. So I left off the qualifying providers, but if you need that information, put a note in the chat and I'll make sure that I follow up with the qualified providers. But I do believe the vast majority of you on this call are going to qualify. So the reason that I want to talk about this is because the FCC has a set of funds available for providers who invest in software and products that are going to help them to provide telehealth services through, right now they're saying through September 30th of this year. So I have the list that's directly from them on the screen, but a couple things that I'm working on right now. One is a software upgrade. So an EMR upgrade for a rural provider who this will allow them to provide telehealth services in their emergency room. And so they're going to get both the cost of the upgrade covered and the increased annual fee for 2020. So with the upgrade in the software, their annual fee is going to go up significantly. So because it's not budgeted for 2020, they can request that reimbursement for this year because it'll be paid before September. And then future years, of course, you'll need to budget, but it'll cover the increased cost for this year. Like I mentioned when someone asked about blood pressure cuffs, you can also purchase equipment for your patients to take home so you can monitor them from home and they don't have to come in. So this could include blood pressure cuffs, pulse ox machines, glucose monitors, things of that sort. And the last example that I have that someone else is applying for is they're actually purchasing equipment for providers in a more urban setting, for a specialist in a more urban setting specifically, to provide telehealth services to their patients in their rural location. So if you're going to purchase, say, an iPad, so a contracted provider, a specialist, say, in Detroit, can provide a service to your patient in the Upper Peninsula, you can put the cost of that iPad in for your funding from the FCC to get it fully reimbursed. And I do see another question came in. Yes, you are correct, Dan. So don't bill the 99421 to 423. Those telephone only codes are going to be under G2025 for that $93.03 reimbursement. So yes. Okay, so but G2025 is not for all all payers. That's only for Medicare, Medicaid. So for your other payers, definitely bill your 99421 to 423 codes. And that's why I mentioned that it's important that you're capturing all of the time you're spending, because there's going to be higher reimbursement from those who don't reimburse based on an AIR for those higher level codes, to make sure that your providers are diligent about that. All right, I do not see any other questions. So Karen, I will turn it back over to you.
Thanks, Julie. So with the CARES Fund, I think that hopefully several of you were pleasantly surprised on 3 Fridays of April to receive quite a bit of funds in your account. Again, the funds were distributed very quickly. They distributed them based on the funds that were available, or the information that was available to them. Again, if you're a provider-based rural health clinic, being part of the hospital, your funds will follow your tax ID number. So they would have received the funds on your behalf. But keep in mind that there was a significant amount of funds. 50 billion was approved and it was distributed over 3 weeks in April. The first 2 funds were distributed distributed basically on Medicare providers and their percentage of the revenue for 2018 across the country. It did leave out the PEDS, obviously, anybody that had a low Medicare provider or did not have any Medicare patients at all. So then that 3rd week, the April 24th, is when they kind of caught back up on those, with providers then receiving a share of their net patient revenue from 2018. But they subtracted out what you had already received the prior 2 Fridays. So some providers actually receive more than 2% those first 2 weeks as of right now. Even though they received additional more than the 2%, they're not going to have to pay it back as of right now. Again, that's subject to change like everything else right now. The terms, but as a independent, then you would have received it directly into your bank account or whatever other source that Medicare has to pay you your funds on a regular basis. It is important that you have to attest to those funds that you received. These are payments, not loans, so they're funds that were given to you. There are obviously still strings attached, so you have to still go in and look at the terms and conditions. You have to agree not to seek collection from out-of-network patients or bill them more than what would be if they were considered in-network. You have to also submit revenue information again, based on that's based on 2018. Very few, we've also put the frequently asked question portal on here too as well. That has changed a few times since they published it. Keep in mind, very few organizations so far have attested to their funds. It's really important to go in and attest to those, to agree to those conditions. And for those independent rural health clinics, they have to verify their net patient revenue in order to receive some of those funds as well. So if you're independent, make sure you're going in and going through that attestation portal so that you can receive your last source of funds. For those that didn't automatically receive them, when you go in and do the attestation, then you will be distributed. They're continuing to distribute funds on a weekly basis as they're validating your information. So that's the general allocation of the 50 billion that was all distributed for the most part in April, unless you need to go in and attest for your revenue, and then you'll receive funds after that. The next source of funds out there is the Rural Health Pool. This was $10 billion. Again, this is extremely exciting in my world, because for rural providers to actually be excluded from the general population is wonderful. It shows that they realize the importance of them, they realize the funding constrictions that they have, they realize the cash flow, and they really want to make sure that those rural providers are being given enough cash to continue to be sustainable for at least the immediate near future. Again, each of these sources of funds is not meant to fix all the problems, but it is pretty significant that they actually carved out $10 billion just for rural providers. It is being distributed to rural hospitals, so critical access hospitals as well as rural hospitals. So again, if you're part of a provider-based rural health clinic, your funds would then go to the rural hospital tax ID number. But if you're independent, you'd be getting them directly. So hospitals, rural hospitals, whether you're a critical access hospital or a rural hospital, they received a base payment of $1 million and then a percentage of their operating expenses. So that's where the provider-based funds would have went. For independent rural health clinics, again, they're receiving a base payment of $103,000 plus 3.7% add-on for additional expenses. Everyone should have received those funds on Wednesday. So HHS kind of threw a loop in there. They were distributing funds every Friday, then all of a sudden they threw a Wednesday in there. But anyway, so it was additional funds that you just automatically received. You did not need to apply for. You might want to go back and do the math on it. And my understanding, it was the going to be based on the most recent cost report, but it looked like for the most part they were basing everything on 2018 because those would have been filed for all the providers out there. So again, additional funds, extremely excited to know that through the different efforts of the advocacy programs that they're able to get a set of funds set aside just for rural health providers. So next, looking at the CARES Act, they actually have a availability there for treatment of uninsured, and these are providers that have conducted the COVID-19 testing or provided treatments after Q4. You need to go into the HHS portal and request claims reimbursement, and it sounds like the reimbursement will be based on the Medicare rates. The biggest question is, what are they determined to be the Medicare rates? Because as a rural provider, your rates are different than everybody else's. I don't think any guidance has been put out there yet is exactly what those rates are going to look like, but they are available as well. And then getting into, there's a lot of other sources out there too. There's private insurance carriers, the state of Michigan through Medicaid. There's grants that are available. The private insurers a lot of times are waiving those co-pays for any COVID-19 testing. And the other thing that we talked about a long time ago, or at least got brought up through the CARES Act, is they actually removed the 2% sequestration for Medicare. So although I know that some of the remittances are not as high as they would normally be, at least the 2% is going to be removed as of 5/1. That will make a change on the cost reports, I'm sure, as well as on the PSNRs to segregate those timeframes out as well. But the sequestration, there will be an additional 2% received back in from Medicare as Medicare claims are clearing after 5/1. Future funds, looking at it through there was $225 million set aside in phase 3.5 of legislation for the Paycheck Protection and Healthcare Enhancement Act. It's supposed to be used to provide funding for COVID-19 testing and related expenses. There's potentially a lot of other sources out there, and it's more of the big unknown because this was a hard presentation to do because usually things have happened, they're done, we've worked through them, we've been audited, we've tested them, and everything's more making sure you have documentation in place and everything else. But with the future, it's really hard to say. 2 months ago compared to today is totally different in place. Everything's changing daily, hourly. You can read something and have found it have changed an hour ago. So it's really hard to say what else is out there. The more important thing is making sure you are getting any funds you can right now, because at some point in time, the sources of funds are going to start slowing down, we hope, from the standpoint that hopefully some of this will start getting behind us a little more, but at the same time, getting as much cash in your pocket as you can right now is extremely important. So another piece about that with getting all the different funds is making sure from a record keeping side. I would strongly recommend creating a separate GL account for all the different funds you're receiving. At some point in time, you're going to have to document them back. We're not 100% sure how they're all going to be affected on the cost report yet. Keep a good spreadsheet as well as just breaking out all the different funds you're receiving. And hopefully those slides prior to this will show the different dates and kind of what the different sources are. But there are so many different sources of funds right now. Try to break out your COVID expenses, whether you set up a different GL account for by department, whether you do a sub account within your department. And I realize, again, this is a little different for provider-based versus freestanding, but it's really important to keep those expenses broken out. And there's a lot more expenses with COVID-related than than you can always think of. So just keep thinking through all the different examples of expenses out there. Protect your canceled visits. That'll be really important to look at, especially when you're looking at your lost revenue, as well as other ways of looking at your lost revenue this year compared to last year. Look at your hours, and the canceled visits also, you want to make sure you're not counting them when you're doing your cost report. Look at your hours of operations changes, because when you're doing your cost report, it's going to be important to make sure you document those hours, especially from an FTE availability time. Documentation and support, again, is key. If this is going to be something that will be audited 2, 3, 4, 5, or even more years down the road, whether it's a cost report, whether it's other funds you're receiving. The government, again, passes out funds extremely fast, but their auditing process is going to take a lot longer than that. And the last thing you want someone to say is that you had too much documentation. They're never going to do that. So it's better to support everything you can now and record keep out and break out as much as you can now and keep your support in place. There are some companies on the payroll protection loan that actually have been advised to create separate bank accounts. If you are a freestanding clinic, if you want to look at, you receive these funds from the payroll protection loan and then keep just paying bills out of that account, that would be another way to possibly separate that out. That'd be a little harder to do probably for your provider-based and your hospitals, but that is how some companies are actually treating that provider-based loan to keep those accounts and those funds completely separate. Again, just keep your record keeping in place. Next, getting into the cost report side of it. Some of it we know, some of it we don't know. The more important thing is making sure from the telehealth side that you carve those out. Telehealth is not going to go through and be affected by your all-inclusive rate. A couple months ago, we had presented or put in front of Michigan Center for Health doing a presentation at their live video or live meeting. It was actually called Getting Paid for What You Do in Your RHC. The cost report summarizes all that up the best way you can. And what Julie covered with the telehealth, that's going to be a carve out that's handled a little bit separately. Just make sure through your cost report you're getting paid for what you do, because everything that's going through the cost report is what's going to be based on your all-inclusive rate. So making sure that with your telehealth, because it's not going to be determined in your rural health clinic all-inclusive rate, make sure you can separately identify everything in there, whether it's the cost, make sure you have your visits counted out separately, because it is going to be a separate carve out. You're going to have to be able to document that, support that, and we know this is an area that the auditors are going to probably really hit on hard starting with this fiscal year's cost reports and going forward. Keeping track of that provider FTE time. Again, it's really important to also look at that and making sure if the office is closed, if they're not available, or what time they're actually there to spend time with the patients. And again, carving out the telehealth piece. Make sure you have an accurate visit count. And some of these, even though we're talking about it right now in the telehealth and with COVID-19, these are important things to do always. Making sure that from a provider productivity exemptions, very few rural health clinics are probably going to meet their exemptions or meet their provider productivity during this time frame because of the office being closed and with volumes going down. As of right now, there's not an automatic exemption for those. So you have to apply for those with WPS prior to doing your cost report to make sure that you can actually get an exemption from those. We're hoping that because of everything going on that CMS will approve an automatic exemption for them, but they have not as of right now. The next area that CMS is looking at that actually they did provide guidance for, one of the concerns is with some of the rural health clinics that are attached to or provider base associated with a rural facility that maybe usually reports 49 beds. They actually did come out with guidance that says that they are going to have an exemption for those as long as they are at the same level. They'll put them at the same level as they were prior to the public health emergency of January 27th. So as long as they were exempt prior to that, if they are in one of those facilities where they increase their bed capacity for inpatient care, they were actually going to allow them to waive that and do that as exemption. So we're kind of hoping that'll happen on the provider productivity side as well, but it just hasn't happened yet. The additional funds too, how do we, we're not sure yet how they're going to look at those. Are we going to have to adjust them off or not? A lot of the funds that are coming in are considered grants, so they would not have to be offsettable. Again, they pay your own protection loan. We've heard a lot of places that it's going to be considered a grant, so you won't have to adjust it off. But if they consider loan forgiveness, then you would have to remove those expenses. So there's still, unfortunately, some unknowns on that, but just keep those in mind as different information is being published out there. Again, the interest side. If you have to pay Medicare back for the advance payment, that is going to be non-allowable interest. But if you have interest associated with other sources, again, that's allowable. So there's another example of breaking that out separately. And again, it's just really important through the cost report because it bases so much of your reimbursement, making sure you have the accuracy and you're looking at all the optimization opportunities, not only during this time, but always. And I see we're getting really close on time. We just have a couple slides left. The next slide, and this seems like forever ago, but when they first came out, they actually did delay the due dates. I'm hoping everybody's fully aware of this, but for the majority of the providers that are at 12/31, normally your cost report is due May 31st. It has a 60-day extension as of right now. More importantly though, Medicaid did not, the state of Michigan did not automatically delay the cost report due date. So it's really important that you go into CHAMS and request a new due date prior to your due date, especially if you're at 12/31. 60 days is a maximum extension that's allowable. The Medicaid auditors are automatically approving this. The junior ends, we're not sure what's going to happen with that yet, but keep in mind that even though they've delayed these due dates, we're still strongly recommending everybody work through their cost. There's 12/31s, work through their cost report now, file them sooner rather than later, so you're not in part of that bottleneck that's going to be hitting the WPS or even the state of Michigan later. So if you can get your cost reports in by their normal due date or as soon as possible thereafter, try to avoid that 7/31 date if possible. And keep in mind too, if your cost report has a receivable, you're going to be getting those funds sooner rather than later. Keep in mind if you had advance payment though, repayment process, that cost report tentative settlement, you could actually use those funds to pay off that sooner too, so you can avoid those interest implications. So if you're concerned about your volume not being high enough to pay back that advance or accelerated payment, you could also look at using that tentative settlement through your cost report if you have a receivable to pay that off, so you don't have interest implications for that. And then we just have one quick last slide for closing thoughts. Not only the funding opportunities that I've ended with, but also the telehealth. Take advantage of as much of them as you can before they change again or before they become unavailable. Obtain all the funding opportunities that you can. Plan as if telehealth is going to end. So we're hoping it's not going to. We know there's going to be some version of that, but plan as if the waivers at least are going to end through the public health emergency. Build your auditable documentation now. It's always important to do that, but even more now because we know a lot of these funds are going to be under heavier scrutiny. Ensure you're using your funds complementary to each other. So if you receive funds for the payroll protection loan for these 8 weeks, you can't use them for others. So you can't commingle the sources of your funds to cover the same expenses or the same revenue loss. So make sure you're using all your funds complementary, and that's where building your documentation is crucial. Expect that there will potentially be more funding opportunities, but is it going to be enough? We don't know when the end of this is going to be yet, and when those funding opportunities are going to dry up, or when this is going to end, or what additional expenses are going to occur. And it's going to take a while for all the revenue to come back and the clinic volume to come back, if it ever will. But keeping all your funding documentation support, I would say forever. I mean, or 7 years in a day, or however, but I would take funding opportunities as long as you possibly can. Keep all your documentation out there. And keep in mind that there's constantly additional guidance still out there. The National Rural Health Association, the NARC, the Michigan Center for Health are all excellent sources. They have distribution lists. Just keep in mind and look for reputable resources though, or thing. Just because it's not on the just because it's on the internet doesn't mean it's true. And I think we were all on listservs that we received a variety of overwhelming information. The funds are distributed and the guidance is coming in slower. We're still waiting for some guidance. And there's a lot of very overwhelming amounts of information and options available. Just take advantage of what you can, because we don't know how long this is going to last and what the new normal is going to look like. And it looks like we're just past 11. So,
Jill and Danielle, do you mind if I take the time to answer that one last question real quick?
Real quick, Julie, I'm going to have Danielle open up the last poll that we have. One of the important parts of our office through the Michigan Center for Rural Health is really that advocacy component, and we're looking for a little bit of information to really understand, how have you used, the next poll, the other poll, Danielle. Looks like the same poll came up, but really to be able to understand that advocacy component, we want to understand where you're at, how you've been using telehealth, so we can take that to Senator Peters, Senator Stabenow, and really advocate for the RHCs and the needs that they have. So Danielle, if you can put that up, and then Julie, if you want to answer that last question, that'd be great.
Yes, thank you for the time. So any recommendations for billing telehealth for patients without an internet or smartphone? So I will directly answer your question and say that there's much advocacy right now for the patients who don't know how to use the technology. They don't have access to the technology. The broadband internet's not available in their area. You should not be, essentially penalized for that. However, I would bill for the telephone service then, because it sounds as though it's not internet or smartphone, but they probably still have a telephone. And I would bill the G2025, document your time, and bill the telephone visit, because that is a fairly generous, in Medicare terms, allowance that they've made. So telephone only can be billed under G2025. So I would go ahead and do that in those instances. And Jeanette, thank you so much. I really enjoyed talking to everyone today.
Okay, I think we're all set. I think we had some challenges with our other poll. So we'll go ahead and conclude if there's no other questions. We appreciate everybody joining today. I hope that you found it valuable, and a very big thank you to Karen and Julie from the Rybar group. We always appreciate your support and your great information. We will send out the slides as a follow-up. And if you have any further questions, feel free to make sure that you email us, and we will get you those answers. We appreciate it, and have a great day.
Thank you.
Thank you.
Bye, everyone.
Bye-bye.